Welcome to today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Alstrom. Now, we would like to thank today's episode sponsor, Takeda Oncology, for their support of Myeloma Crowd Radio and all they do for myeloma patients. They really stand out as an organization that supports patients not just by providing life-extending drugs, but supporting the patient community as a whole. Now, before we get started on today's show, I'd like to share a little about our Myeloma Crowd Research Initiative campaign. This is the first time that a group of united patients have come together with top myeloma research to find potentially curative research for high-risk myeloma. So why high risk? These patients do not do well on today's therapies compared to other patients, and we believe that it's a top-down approach that will ultimately help all patients. Our 8-month search led us to 2 important projects that now need our financial support, and both projects are ways to use the immune system to fight myeloma. To our delight, they are just as exciting for normal and low-risk patients as they are for high-risk patients. So we invite you to help raise funds for this proposal by creating your own fundraising page that you can share with friends and family. So you can go to the myelomacrowd.org website for links that you'll see at the top to create your own page. Now on to our show, which is also about the new and hot topic of immunotherapy. We would like to welcome Dr. Atanackovic to talk with us about the timing and use of immune therapies, as well as other projects he has going. So welcome, Dr. Atanackovic.
Yeah, thank you so much for inviting me today. And I'm happy to talk a little bit about my own field of interest, which is and has always been immunotherapy for cancer. So I'm very happy to talk about this topic today.
Okay, well, we're very excited to hear about it. So let me first introduce you before we get started with our questions. And I will just share a little bit about you. Dr. Djordje Atanackovic is Associate Professor of Internal Medicine in the Hematology BMT Division of the Huntsman Cancer Institute. He is board certified in the Hamburg Medical Council's Oncology Hematology Division and received his education at the University Medical Center in Hamburg-Eppendorf in the Oncology Hematology Transplant Division and the New York branch of the Ludwig Institute for Cancer Research. His deep research focuses on blood cancer immunology. He's a member of ASH, the European Hematology Association, ASCO, and both the American and European Associations for Cancer Research. He's a grant reviewer for a list of worldwide organizations, including Cancer Research UK, German Cancer Aid, and cancer organizations in Austria, Belgium, Italy, and Spain. His awards include grants from the University of Hamburg for the Excellent Young Researcher Award, and also from the Cancer Research Institute and German Cancer Aid. He has 3 patents related to myeloma and an additional patent in progress. He is editor of BMC Cancer and is a representative of the Huntsman Cancer Institute on the NCCN Multiple Myeloma Panel. Dr. Atanackovic's research interests and deep roots are in immunotherapy, as you said. So welcome again.
Thank you. Thanks.
Dr. Atanackovic, maybe you want to first begin by explaining the difference between gene therapy and cellular therapy.
Yes, there's really, so when you mentioned gene therapy, and really the traditional way of thinking of gene therapy is really, or used to be, that we tried to correct or repair genetic defects that cause cancer, really. So this were the first steps of a gene therapy, to repair genetic changes that can cause cancer. And this, to my mind, this hasn't so far been too successful, this approach, really. And that's why probably very recently we used gene therapy to modify the patient's immune system. For example, by collecting peripheral white blood cells from the patient and then use genetic approaches to make these cells tumor specific in order to retransfuse them into the patient, for these cells to destroy tumor in the patient's body, really. So this, I think, is the general difference. So these days we're using gene therapy in order to improve cellular therapies. That's what we are doing right now. And
so can you give us some examples of gene therapies?
Yes, right. So for example, so I'm an immunotherapy expert, let's say, and so for for different types of cancers, we've tried to use the human immune system for a long time, for decades, basically. And the first type of cellular immunotherapy at that point without gene therapy was actually the use of donor lymphocytes in patients who had an allogenic transplant. So you would take donor-derived immune cells, infuse them in the patient in the hope that these foreign immune cells will destroy the patient's tumor. But unfortunately, this approach was very toxic in the sense that these are foreign cells which will not only attack your tumor cells, but at the same time will also possibly attack your healthy tissue. So it's the DLI approach, the donor lymphocyte infusion approach, is still very toxic because a lot of patients will have develop graft versus host disease. So we try to optimize the cellular immunotherapy approach, for example, by using tumor-infiltrating lymphocytes. So that's what that people have done for patients with a certain type of skin cancer, which is melanoma. So they've resected the patient's tumors and then removed the immune cells present in the tumor tissue, expanded these immune cells, and then retransfused them into the patient, the tumor-reactive cells back into the patient, and they've seen remarkable responses with this approach, with the tumor-infiltrating lymphocytes in patients with metastasized skin cancer, for example. But again, this is a very demanding approach and technically very demanding, and you can't possibly do it at every center across the country or internationally. So that's why we've very recently started to use gene therapy in combination with cellular immunotherapy, in the sense that we will now collect the patient's immune cells just from the peripheral blood, their own immune cells, their own white blood cells, and then use gene therapy on these cells, in the sense that we will, by introducing a novel receptor into these cells, we will make them tumor specific. And then we will retransfuse these genetically modified T cells, which are CAR T cells. You've probably heard of this approach, or T cell receptor transduced T cells. We'll retransfuse these now tumor-specific T cells into the patient, and this has also led to remarkable responses in certain types of lymphoma very recently. So this is how we nowadays combine basically gene therapy and cellular therapy.
So it sounded like from other shows that we've done that typical stem cell transplant is considered cellular therapy, but what you're saying is that there are other immunotherapies that are also considered cell therapy. Is that correct?
Exactly. Absolutely, that's correct. And I think this is because we've noticed and we've seen that these, like the classical autologous transplant, for example, or the allogenic transplant, there's great need for optimizing these approaches because, as you mentioned in the introduction, these classical approaches are still not effective enough, for example, for patients with high-risk multiple myeloma. So that's why we've used the most recent advances in the research to make your own immune system more tumor-specific and more effective in the fight against the multiple myeloma.
Okay, perfect. I think we'll get into the tumor-specific a little bit later. So what I hear you saying is, and there seemed to be a gene-targeted movement growing about a year or two ago, and maybe it's grown for longer, to say, gosh, can we find a certain protein or target on the cells and then just go after that target? And what you're saying is now that you're trying to combine those two different approaches versus there's just one single approach. Is that what I hear you saying?
Yes, exactly. I think you're absolutely right. I think it's really still very true that we are, as myeloma experts, are supposed to tailor treatment, to provide personalized treatment. So, and that's what we will still do. I think this is still has been a major improvement in the field, that we're now able to, like in a molecular fashion, define the characteristics of the disease of the patient. And that's, even in the age of immunotherapy now, is still very important to find out what are the genetic changes present in the patient's myeloma, for example, and then tailor to the treatment not only according to the molecular characteristics of the tumor, but also obviously according to the individual characteristics of the patient. So I think you're right. I think we're still these days supposed to personalize the treatment, find out what's the best treatment for this individual. But we think that multiple. So the problem is, with a patient, for example, let's say a patient who has high risk multiple myeloma with a deletion 17, a p53 mutation. We know that they're at a very high risk for a comparably higher risk for a relapse, for example, after standard treatment, including transplant. But we don't know how to overcome the risk. So we're trying to overcome the risk in this patient by intensifying their treatment, but we haven't been too successful in the group of patients with high-risk disease. And I think, and I'm very hopeful, that immunotherapy will eventually be able to overcome the risk associated with these genetic features of the patients. So I'm very hopeful, and I think also our first data indicate that yes, this will become true, and we will find an optimized immunotherapy even for patients with high-risk multiple myeloma.
Well, I agree, and I'm very excited for immunotherapies, and I think patients are so excited about immunotherapies, just because they're still powerful, but they could potentially reduce some of the need for chemo. I guess that kind of brings us to the next question. So we've had several shows where we talk about that, where doctors have said that there are really windows of opportunity to use immunotherapies, that sometimes you might use them at a certain period of time in your treatment, and sometimes they wouldn't work at all. So can you maybe explain what those windows are, and then when they're best used? We've heard maybe when there's a low tumor burden, or is it after transplant? Is it best for when you're relapsed refractory? Can you even use it at that stage, or maybe even for smoldering?
Yes, right. That's a very good and important question, I think. So first of all, I think the question whether the human immune system can help in the fight against cancer has a very long history. I think they started as early as in the 1920s to do first experiments, even clinical experiments with patients, and I think the first really approach was really cancer vaccines, I think, and that's the idea behind cancer vaccines is really to train the human immune system. So you wouldn't genetically modify, do anything outside of your own body, but you would just administer a vaccine and try to make your immune system help in the fight against cancer, really. So by administering a vaccine, and this approach has been very effective in preventing infectious diseases, as we all know, right? So we've tried for a long time to develop cancer vaccines, and most of the time this approach has actually failed, unfortunately. But I think so. This was the first type of immunotherapy, which we consider an active immunotherapy, because this by administering a vaccine, you basically, as I said, would train your own immune system, and so your body would actually play an active part in the whole thing, and then later on we found out, as I said, that cancer vaccines are not always effective. In fact, most of the times these treatments failed, really, and that's why we developed other types of immunotherapy, which we call passive immunotherapies. For example, monoclonal antibodies we all have antibodies in our body. They're part of the immune system, and the antibodies target, for example, virus cells infected by a virus. For example, that's what antibodies can do. They target viral infections. So we developed antibodies against different type of tumor cells because your own body is most of the time not capable of developing an effective immune response against the cancer. So that's why we artificially made antibodies and gave them to the patient, which resulted in significant clinical responses in a number of cancers such as non-Hodgkin's lymphoma, where we have the antibody rituximab. We've had this antibody for 2 decades, basically, and it's been very, very effective. Right? And only very recently, we've developed the first anti-monoclonal antibodies for multiple myeloma. None of these treatments have been approved so far. For example, the antibody against PD-1, or the antibody against one of the surface antigens present on myeloma cells, the antibodies against CD38. So the clinical results with these antibodies look very promising, but they're not approved yet. I think these antibodies will receive approval very soon, hopefully early next year. And then finally, there are cellular immunotherapies. So where I just mentioned, so in this case, we basically collect the patient's immune cells and modify them in a certain way genetically, for example, and then retransfuse them into the patient. So these are, I think, the things I just mentioned, these 3 types of immunotherapies, vaccines and monoclonal antibodies and cellular immunotherapies. I think these are the 3 major categories of immunotherapies. And I think for all of these treatments, there's a certain window of time or window of opportunity. You can use them. But again, most of these treatments have not even been approved, so they're not publicly available right now. So if you ask me, now I'll come back to your question. So one of your questions was, can we use immunotherapies only in the case of a low tumor burden? No, I don't think so. I think there's immunotherapies for all stages and phases of multiple myeloma. There will be immunotherapies for all the different types of multiple myeloma. I think it's true that at some point in time we thought that it's, in the best case we'll have only a very small tumor burden because this is the only thing the immune system can do. Overcome minimal residual disease, maybe. But that was the time when we had only vaccines available, which, as I said, weren't very effective. I think these days our impression is that the more, let's say, up-to-date or more modern versions of the immunotherapies, like the genetically modified T cells I mentioned, the cellular immunotherapy, or the monoclonal antibodies, are capable, absolutely, to fight large tumor burdens as well. So I would say these days we have a number of different immunotherapeutic approaches for all the different settings. So, and if you want, I don't know if you want me to go in a little more detail and explain, for example. So I could give you an example, for example. So in a patient, for example, who has a very low tumor burden, for example, a patient after transplant, who and they have just minimal residual disease, a few tumor cells persisting in the bone marrow. So in these patients, I believe probably at some point we can hopefully use a vaccine to keep these cells under control, or maybe even eradicate these few remaining cells in the bone marrow. So this would be a window of opportunity for immunotherapies that are less effective maybe, but also less toxic for the patient in this particular setting. Or the same thing for smoldering myeloma, patients who do not have any symptoms at all. Really, you don't want to expose them to severe toxicity, so we'll have to find an immunotherapy for these patients that's not toxic. Right, so that's the goal in these patients. And then again, a different type of patients who have relapse disease, a massive, a rapidly progressing disease, maybe in those patients you can wait and do something that's not effective. You'll have to come up with something that's very effective and will work very rapidly. So in these patients, I would probably use a different type of immunotherapy. For example, one of the new antibodies that will be approved in combination with Revlimid, and they've shown that these combination treatments, immunotherapy plus an IMiD, is very, very effective and will work in the vast majority of the patients too. So in this case, I would use a different type of immunotherapy, or maybe even a cellular immunotherapy if available inside of a clinical trial. So what I'm saying is really we're developing different tools, different types of immunotherapies for all the different phases of the disease. Patients with low levels of the disease, patients who have massively progressing disease. And then again, as I said previously, the plan is to individualize treatment and personalize treatment. You can pick the individual tool really out of the many immunotherapies we will have available in the near future, I believe.
Well, I think that's so exciting because I think that technology is getting there where you can target certain genetic features. In addition, we had another doctor say, you really need to know your genetic features, but you also need to understand that patient's immune system, because what you were saying is that you can decide and pull out these tools that you're talking about and, like you said, use vaccine when somebody is and has no tumor burden or a smoldering myeloma, and the monoclonal antibodies like the daratumumab and elotuzumab, which are hopefully going to get approved soon in the next few months, and then the T-cell treatments that you're mentioning as well. So I think it says that you really need a specialist who understands your disease and who understands all the tools that are in that toolkit.
Yes, I think so. I think you're absolutely right. But this has always been to a certain degree the case for multiple myeloma. I think the first thing, as you all know, is the first and most important thing is really in the treatment of multiple myeloma is understand who is the patient really. And I'm not talking only about as I said, the molecular characteristics of the tumor cells, but also who is this individual really, what's their background, what are their comorbidities, and even the social background and everything. So you really have to find out who is this patient, what does their tumor look like, and then you'll have to define a goal. And these days this includes the whole spectrum of treatment with immunotherapies as well. But it's always been the case that you'll have to get a detailed picture of whom are you dealing with, basically.
Mm-hmm. And it sounds like that with the monoclonal antibodies coming up, and then it seems like all the T-cell research is right behind it, but a little bit further behind, and it looks really promising. Would you look at using those two things together? I know you'll have to test them by themselves first, but are there stages where you would say, well, at this stage, I think a monoclonal antibody like the SAR or the daratumumab or the elotuzumab is a better choice, and then later on we're going to use CAR T-cell, or we're going to start with the CAR T-cell stuff, and then all the CAR T-cell stuff is in clinical trials, like you were saying, but I'm just wondering how you would determine what and when to use it, especially with the current drugs that we have.
Yeah, right. So I think that's a very good question too. I think, and this is so. For multiple myeloma, I think one of the hallmarks for multiple myeloma, which really makes it very different from other tumor types, is really that you have enormous immunosuppression in the bone marrow environment of the multiple myeloma cells, and it's actually, we've done a lot of research on this aspect. So that's what multiple myeloma is actively doing. So it's creating its own immunosuppressive environment in the bone marrow to protect itself from an immune attack, really. And that's, you could say it's fascinating too, how this disease creates its own comfortable environment in the bone marrow and it attracts, for example, immunosuppressive cells into the bone marrow to protect itself from an immune response, and it produces all kinds of immunosuppressive soluble factors, and so forth. So there's a huge network of immunosuppressive factors around the multiple myeloma cells in the bone marrow. And that's why I think it's not that easy. It will turn out that it's not that easy for multiple myeloma compared, for example, to non-Hodgkin's lymphoma. I think for multiple myeloma, the solution is really you'll have to combine different approaches so for example, combine a cellular immunotherapy, genetically modified T cells, for example, with an antibody against PD-1, immunosuppressive surface molecule in the bone marrow. So combine different treatments, or for example, as you've mentioned, the antibodies, the novel antibodies, the daratumumab or the elotuzumab, have been shown to be very effective, but only or mainly when given in combination with an IMiD, just like Revlimid, which will change the bone marrow environment. So I think that's really the solution, the key point for multiple myeloma. You'll have to probably combine different types of immunotherapies in order to fight the disease effectively.
And with what you're seeing with the CAR T-cell stuff versus the monoclonal antibodies, would you see one being better than the other, like with a high tumor burden? Is one going to be more powerful than the other, or will they be just kind of combined?
I think that's really what it is. I think it's so for the antibodies, they're a little further ahead. I think so. The antibodies have been tested in large clinical trials, like the daratumumab and the elotuzumab, and it's been proven really that they are very effective, even in the setting of a large tumor burden, patients who've had a number of previous treatments and who are basically resistant to other types of treatment. And the antibody, when given in combination with, for example, Revlimid, will still be very effective. So this has been shown in a very large trial and will lead to the approval of the first monoclonal antibodies very soon. For the cellular immunotherapies, I would say it's still a little early. It's still a little early because we don't have too many clinical results right now. So it's a little too early to say really what's the role of cellular immunotherapies. I'm actually hoping for, and I think it's very possible that these approaches will turn out to be very effective, but it's just that it's a little early right now to determine exactly the role of these cellular novel immunotherapies for multiple myeloma. But if you ask me, same thing. I think we will end up combining, for example, antibodies with the cellular immunotherapies, and that will be probably the most effective approach for multiple myeloma.
Mm-hmm. And in today's environment, what do you see as let's say these monoclonal antibodies get approved, what do you see as standout combination treatments right now? And for which stage of disease, I guess?
Yeah. So I think right now, as of today, basically, I would say it's probably the antibodies and the novel antibodies, and there are more antibodies like under development right now, but the novel antibodies given in combination with the standard treatment, just like the Revlimid. And this is very fascinating because for some of the monoclonal antibodies, like the elotuzumab, they tried them as a single agent. So they administered the antibody to patients with relapsed multiple myeloma, and it didn't work. There was no response at all. So with the elotuzumab as single agent, and then somebody luckily came up with the idea to combine the antibody with Revlimid in patients who had previously had the Revlimid already and maybe even failed it, right? So, but they combined it because they thought, this is called an immunomodulatory drug. That's what the IMiD is, really. So why not combine it and give it a try? And then they found that they observed enormous responses when given as a combination with the antibody plus the Revlimid. I think it's really, really fascinating. It just shows how important the tumor microenvironment, the bone marrow, the immunosuppression in the bone marrow is really, and that you really need to overcome the immunosuppression in the bone marrow environment before you will see a response to any of the new treatments. So I would say this has been the most dramatic change and achievement, I think, in the past few years. I think it's the monoclonal antibodies and the fact that we found out, luckily, that you need to combine them with a standard treatment like an IMiD, for example.
So that brings up another question. Do you ever see immunotherapies replacing ever the traditional drugs like the proteasome inhibitors or the IMiDs, or they'll always be used in combination, you think, with those because they help boost the power, I guess?
Yes, right. I think that's the point, really. I think as of today, just looking at the data we have and at the clinical trials, the most recent clinical trial, it doesn't look like the immunotherapies will replace all the standard treatments, but on the contrary, it looks like you need, as I said, you need to combine the standard treatments and the IMiDs, for example, with a novel immunotherapy, and that's when the treatment will be most effective. So I'm not sure, I can't predict with certainty, but right now it looks a little more like the appropriate way to develop new treatments is to combine combine different versions of immunotherapies with standard treatments like an IMiD or a proteasome inhibitor. And this may very well change, but I'm talking about what do the data tell us right now.
Right, and you have to work with what you have right now before. And it's tough because when you look at something new, you're not looking at it in combination. You're just looking at it by itself first, and then
exactly,
and that comes later.
And that's how it is. So it could have perfectly well failed, like when they had, as I said, the first results with the elotuzumab antibody, and they found out it doesn't work. Somebody could have said, you know what, let's just forget about it. Let's not invest any more money in this, and let's just forget about it. And then someone came up with the idea to combine it, and they were successful. So this is really, it's very fascinating. And on the other hand, I think you are right. I think probably, and that's how it's always been in medicine. I think novel treatments at some point in time will probably replace older types of treatment. I think, for example, I'm not so sure we'll do as many autologous transplants, just standard autologous transplant in 10 years from now, I think, because we will probably and hopefully have less toxic and more effective types of cellular immunotherapy, just like the CAR treatment I just mentioned. So I'm sure that some types of treatment will be replaced at some point in time.
Mm-hmm. Well, I think everybody would be excited to just get to a cure, no matter what combination that would be.
Yeah.
So I see that you have done research on cancer testis antigens, and I know this has to do with immunotherapy. So maybe you would like to describe what that is and how it works, because I'm not sure what that is.
So first of all, this is a certain type of protein present mostly. So it's a certain family of proteins present inside of the tumor cell. So we just mentioned all the different antibodies which target proteins present on the surface of the cell. That's the only thing an antibody can do. It can target and something present on the surface of a tumor cell. These proteins, the cancer testis antigens, are present mostly inside of the cell. You can't find them on the surface of the cell. But that's fine, because there are all kinds of things the immune system can recognize inside of the cell, because that's what cells do. Basically, they present many of the proteins present inside of them. They present them on the surface in the context of HLA molecules. So, and the purpose of this is to demonstrate, for example, in case of a virus infection, that cell will present certain parts of the virus to the immune system on the surface, cell surface, saying, that's me, I'm infected, please kill me. So that's the purpose of this whole thing. So intracellular proteins are presented on the cell surface in the context of HLA molecules. That's what evolution has developed, basically. And so that's what we can use. So we can actually target proteins present inside of a tumor cell. CT antigens, cancer testis antigens are intracellular proteins which play a very important role, I think. So they are only expressed in tumor cells, no cancer testis antigens expressed in normal cells, which is good, I think, because this is what we want. We want to target a structure that's not present on healthy tissues, obviously, because we don't want any toxicity, really. And we think that these proteins, the cancer testis antigens, play also a very important role in the development and progression of multiple myeloma, for example. My group has shown that there's practically no multiple myeloma without a cancer testis antigen inside of the cell, really. So, and these cells, these proteins, if you remove them or suppress them, basically myeloma will stop to grow. Basically. So this plays a very important role. It's not only a target for immunotherapy, but these types of proteins play a very important role in the progression of the disease too. And that's very important too, I think, because this way the tumor can't afford to just downregulate or get rid of the protein in order to, evade the immune control here. So because it can't survive, the tumor cell can't survive without cancer testis antigens. That's why it has to will continue to express the antigens, and we will be able to continuously target these structures really inside of the cell. How can you do it? How can you target these intracellular proteins? You could do it, for example, by using genetically modified T cells. Again, T cells a little bit different from the CAR T cell approach you just mentioned. So you would have to genetically modify these T cells in the case of cancer testis antigens by introducing a different type of T cell receptor. So again, that's how we can probably will be able to effectively target cancer testis antigens expressed in multiple myeloma. And I can tell you there's a number of trials ongoing and a number of genetically modified T cells under construction right now that will target cancer testis antigens in multiple myeloma. Multiple myeloma is the one tumor type that shows the most frequent and strongest expression of cancer testis antigens out of all the different tumor types.
Oh, that's fascinating. So what you're saying is if you can get inside the cell, maybe you can do a few things. You can make sure that just because it has it on its surface, because sometimes you're saying the cancer cells lose that signature because they get tricky, and they lose the signature even though they're still developing myeloma. So by going on the inside of the cell, you're kind of killing it at the origin. That's what it sounds like. Is that
exactly
correct?
Yeah, that's absolutely correct.
And how is this being done? And then how, if you could compare it, please, to the like the monoclonal antibody work and the CAR T cell work, like where is this at in terms of development?
Okay, so yeah, right. That's a very good question too. So the general difference between CAR T cells, for example, and monoclonal antibodies versus the vaccine approach, for example, or the T cell receptor transduction approach is really that antibodies and CAR T cells target surface molecules expressed on myeloma cells, for example. The problem with these approaches is that very often you won't be able to find a surface molecule present only and specifically on multiple myeloma cells, or you won't be able to find a molecule that's expressed on all the different myeloma cells in every single patient. So that's the problem with surface, because they are very often not specifically enough expressed on the tumor surface. You won't be able to find a perfect tumor antigen expressed on the surface. So that's why, for example, let's say the novel antibodies, the daratumumab, which targets CD38 on the surface of multiple myeloma cells, will at the same time kill all kinds of plasma cells, all the normal plasma cells probably, which are also positive for CD38, and the number of T cells and so forth. So I'm just saying, so there is probably no perfect surface molecule. You will always also target at the same time healthy tissues. And that's not the case for intracellular proteins like the cancer testis antigens. We have identified a number of proteins that are only and specifically expressed only in tumor cells, and that's why approaches targeting these proteins will hopefully be less toxic and more effective. But right now, as of today, the antibodies and the CAR T cells targeting surface molecules are very close to the clinic and will be approved very soon, while the other approaches targeting intracellular proteins are still under development. And I'm only aware of one large trial that was very recently published that targeted the cancer testis antigen using genetically modified T cells. So this still needs a lot of time for development.
Mm-hmm. And can you explain how it works? Like, what would the treatment look like if in that trial or in a trial that uses the antigens?
Right. So they've recently. So then this is a very fascinating approach. So as you probably know, they've recently combined two different approaches. So they've combined an autologous transplant, so high-dose chemotherapy, high-dose melphalan, followed by an autologous transplant. And then on day 15, after transplant, which is the point in time when most patients will show recovery of their blood cell counts. And so on that day, they gave the patients CAR T cells, for example. And I think that's a very reasonable design of a clinical trial. I think to combine it with a transplant. I think that's not what most people have in mind when they talk about immunotherapy. And but I think that's for now is probably a very reasonable design. Really, I think that's what a number of trials will do, to combine it with an autologous transplant and give these CT antigen, cancer testis antigen specific cells, for example, within the framework of an autologous transplant for a number of reasons. Because one of the reasons is that you will have an empty bone marrow, you will have a lot of space in the peripheral blood. So these newly developed T cells, they can easily expand and grow in the bone marrow and in the peripheral blood of the patient, and then multiply basically and fight the myeloma more effectively. So I think this would be probably one of the possible designs for such a study.
Mhm. Okay. And then so we were doing a show about the marrow infiltrating lymphocytes, and it sounded like that sample, let's say you were going to do an immunotherapy on a patient, that sample was from a bone marrow, and most of these other are coming out of the blood. So what do you use for this cancer testis antigen approach? You just take it out of the blood and then you engineer it. How do they engineer it to target the inside of these myeloma cells? I think that's really fascinating.
Yes, right. So for a T cell in general to recognize an intracellular protein, so we have millions of different types of T cells in our blood, which basically patrol the blood and like on a 24 hours a day, basically, and they will look for their specific little piece of a protein they can recognize. So one T cell can only recognize a certain little piece of a protein, let's say of a viral protein or of a cancer testis antigen, and that's why we have millions of different T cells in our blood, really. And that's what makes it generally a little difficult for the immune system to find the tumor cells in the first place, because the number of pre-existing T cells specific for the given antigen is just simply too low. So it's just to a certain degree, it's just a number really that's the problem, really. So that's why we've started to the basic idea was, why don't we remove the patient's or collect all the patient's T cells and make all these cells specific for the let's say for a given cancer testis antigen. That's actually how we do it. So you can collect a patient's white blood cells, including all the T cells. Then you expand them, grow them in the lab, basically, and then you introduce a new T cell receptor, so a receptor that's specific for the given cancer testis antigen, and make all the patient's T cells specific for this given target, basically. So millions. I'm talking about let's say 500 million cells, basically, and then you will retransduce these T cells with a new T cell receptor into the patient's peripheral blood, and then these cells will be able to recognize all of the cells. 100% of the 500 million cells will be able to recognize and kill cells expressing the given cancer testis antigens.
So that's amazing that you can train them all to go after one kind. So are there just, like, let's say a patient has different types of myeloma cells in their body, does it just go after one of those kinds, or you're training it to go after all the kinds that particular patient has in their system?
That's a very, very, very good question, and that's why. So I've mentioned a number of characteristics that we think are positive for a given tumor antigen. That we think it's of an advantage if your target plays a role in the progression of the disease, because that way the tumor can't afford to lose its expression. So that's the one thing, I think. And then what you want, and I mentioned that too, is really you want a target antigen that's only expressed in or on tumor cells, but not on any healthy tissues, because this way you will avoid toxicity. And then the third criterion, which you just mentioned, basically, is we would like to come up with a tumor antigen that is expressed in all the patient's tumor cells, so a homogeneous expression in all them, not just in 95% of the patient's tumor cells, but an expression in all 100% of the patient's tumor cells, and then another advantage would be to have an expression or the presence of the given antigen in all the different myeloma patients, right? So in 100% of the myeloma patients in an ideal world, and in all of their tumor cells. And that's not the case for too many targets these days, but there are a number of cancer testis antigens, for example, which are expressed in 90% of the patients and in all of their tumor cells. So I think this way we wouldn't even have to test the patients. If we think it's expressed in 100% of the patients, you wouldn't even have to test them. But for the clinical trial, for example, the one I just mentioned, which targeted a certain cancer testis antigen named NY-ESO-1, so they tested the patients. You can take their bone, collect their bone marrow, and then test the expression, evaluate the expression of the target antigen in the patient's bone marrow, in the patient's tumor cells. That's how they did it for that trial, for example. And I think it turned out that 20% of the patients only expressed the antigen of interest.
And that was my next question. How do you test for this? So it's part of a bone marrow biopsy?
Yeah. So since the tumor cells in the case of multiple myeloma are only present in the bone marrow, or primarily present in the bone marrow, that's why you have to do a bone marrow biopsy. And then that's what we've done for hundreds and hundreds of patients in the past. So we've collected their bone marrow, and then you can apply a number of assays to determine the expression of the antigen of interest. For example, you can do a PCR, or you do immunohistochemistry. You could even do a gene array. You can do all kinds of things to evaluate the expression of the given antigen in a particular patient. So I don't remember how they did it for that trial, but it's not that difficult, really. The only thing is you'll have to do a bone marrow biopsy.
Well, that's fascinating, because I've seen all these approaches to target the top of the cell or the surface of the cell, and I haven't heard much about this at all. That's amazing. So
yeah, as I said, so recently they completed I think it was, if I'm correct, was it an NIH? I'm not very sure right now, but they completed a large trial with TCR transduced T cells targeting the cancer testis antigen NY-ESO-1, and they achieved some remarkable responses. It's not that easy if you don't have a large trial and not a randomized trial to clearly demonstrate that it's the new approach only. That because, as I said, they combined it with chemotherapy, so it's hard to say in such a trial, how effective was the cellular immunotherapy in the whole framework of the whole approach, really. But that's how they did it for the trial. So it was recently published only.
Wow. Okay. Well, that's exciting. So we look forward to hearing more about that. Now, there were two other topics that I saw that you were doing research on, and we probably have time to just talk about one. I'm looking at the time. The time goes by so fast.
Yeah, right.
So I know that we'll be hearing more about PD-1 and PD-L1 from ASH, and it is considered an immunotherapy. And I know you're working on that, and you're also working on CAR CD229. So maybe you want to pick what you would like to talk about.
I can just explain briefly. I think the anti-PD-1 approach is a very antibody is a very fascinating thing because it's not targeting like the antibodies I just mentioned. I told you. So these antibodies, they target a molecule present on the surface of the tumor cell. So they target this tumor cells directly, while this new antibody doesn't even target the tumor cells, but it targets the immunosuppressive environment of the multiple myeloma cells. So what the anti-PD-1 antibody does, for example, it doesn't kill even the tumor cells, but it helps the immune system, and it removes the brake. That's how they call it. It removes the brake from an effective immune response on T cells. So it's actually targeting the immunosuppressive environment of multiple myeloma. So it's an antibody as well, but the whole approach is very different from classical antibodies. Very, very fascinating. I think I'm very optimistic that this will, result in a very nice response. And our own group, and then again we defined another molecule present on multiple myeloma cells, which we're in the process of developing an immunotherapy again for this molecule, targeting this molecule, which is CD229. It's expressed in all the patients' multiple myeloma cells. Unfortunately, it seems like it's also expressed on some healthy cells, normal cells, as it is the case for most surface antigens. This is what I just mentioned. But we're very hopeful that we will still don't see too much of a toxicity, and that this approach will be very effective in multiple myeloma. Actually, we're making CAR T cells targeting CD229 right now in the lab, and we'll test them very shortly in vivo and find out.
Wow, that's fascinating. So where will your research take you next, primarily, with all these different immunotherapy approaches and with a background in immunotherapy? What do you see as the most exciting and promising, and how do we get it out the door faster or in combination? So it's because as a patient, I listen to you talk and I say, gosh, well, I would like to use the PD-1 and the PD-L1 to take the brakes off my immune system, but I'd also like to kill the tumor burden that I already have. And, so how do you prioritize, I guess, as an immunotherapy expert?
I think the thing is really, I think we don't have the time to prioritize. We'll have to do everything at the same time and evaluate, I think, as I just said. So we'll have to determine what's the efficacy and the toxicity of all the different treatments used as a single agent, and then we'll have to, start to do combination trials in parallel. I think this is the only way how we can speed up the process. I think by doing studies in parallel, do single agent and then combination treatment, because that's what we've seen in the past. Combination treatments are more effective than single agent immunotherapies, I think. So that's how, in general, how I would do it. I think, and then we just started to develop something here, which is a very novel approach. So we will have something called a cellular a platform for cellular immunotherapies here at the Huntsman and at the University of Utah, and then hopefully, the idea is really, for, let's say, if you were a physician treating patients with multiple myeloma, you could come to us and you could tell us, I have so many patients who are in need of these novel treatments, and I don't have any clinical trials going on because I'm not a researcher, I'm just treating patients. And then we would help you to develop your own type of immunotherapy and develop the whole product really, and provide you with a product you can use in your own clinical trial for your patients within a few months only. So that's what we're building right now here at the university, and that's the other way of how I think, hopefully we'll be able to get there faster, I think.
Well, that's a very new approach and a way of thinking about it, because you have all these local oncologists who are trying to treat myeloma when they're not necessarily a specialist, and now you have combinations and immunotherapies and new drugs coming out, and wow, that's a challenge for them to properly treat myeloma.
Yes, right. And I think this is really how we should do it. I think we shouldn't focus too much just on our own lab and group and things like that. So the goal is really to provide new treatments faster and more effectively for different diseases, different tumor types, and different clinical investigators, really.
Okay. Well, last question will be, before we open it up for caller questions, is what's the value to you about patients joining clinical trials?
That's the key issue, really. So we really should make very clear that, in particular also for multiple myeloma, I think numbers of patients treated within clinical trials are still way too low, I think. And so this is what we have to raise awareness and make very clear that there won't be any advances without clinical trials. I think for multiple myeloma, we should try to treat the majority of our patients within clinical trials. Unfortunately, that's not the case today, really. But this is of major importance, I think.
Well, that's terrific. Well, we're really excited that you're working on this. So we would like to open it up for caller questions. And if you have a question for Dr. Atanackovic, you can call 347-637-2631. Okay, our first caller, 949-5572. Go ahead with your question.
Oh, hi. This is Paul. Thanks for taking my call. In the past, Huntsman has done tandem transplants. And are you guys continuing to do the tandem transplant therapy, or is that not a therapy that you guys are pursuing? I don't know. I didn't listen to the whole show. So you might have talked about it earlier on, but I didn't catch the whole show.
No, I haven't. We haven't mentioned the tandem approach, and it's true that the Huntsman, like in the past, treated most of their patients, the vast majority, with a tandem approach. So, and this was based on the total therapy approach developed in Arkansas, and no, we don't do that anymore. I think we're part of the NCCN network, and we should, I think, adhere to our own guidelines, which are really based on the clinical trials. And there's really no solid evidence so far that the tandem approach is the optimal approach for all the different types of multiple myeloma. So we're actually not performing tandem transplants on a routine basis for all of our patients. We still do it for a minority of patients who do not respond well enough to their first transplant. But for the majority of patients, transplant-eligible patients, we will only do one transplant probably.
Okay, and then I have a follow-up question, if that's okay.
Mm-hmm.
As it relates to the show, how long do you think it'll take to get the CAR T cell into clinical research?
So it's already in clinical studies, and that's already the case nowadays. And I think so for the first CAR T cells to be approved, by FDA approved, I think the timeline of the companies involved is really, I think the plan is to have the first ones approved in 2018. And for multiple myeloma, it's really, I can't give you a specific date, right? And I know right now there are a number of studies going on, different places with different antigens. So there are a number of clinical trials with CAR T cells actively recruiting multiple myeloma patients as of today, but I can't possibly give you a specific date on when exactly will these studies, these agents be approved.
All right. Oh, awesome. Hey, thank you so much for and great interview, and thanks for all you're doing there.
Thank you.
Thanks. Welcome to Utah.
Okay, thanks.
Exciting.
And I have a follow-up question to that. So when you say it's about 2018, or I know they're just entering clinical studies right now, it's really early. What would you say for the cancer testis antigens? Like maybe 3 to 5 years, because it seems to be kind of a step behind that, and then. What do you think?
Yeah, sounds reasonable. I mean, that's what I would hope for. I would say 5 years is probably reasonable, I would say. That's what I'm hoping for.
Well, I think at that point you'll have a really good idea about how these work and how they work together. And Dr. Atanackovic, we're so grateful for your participation on the show today.
Okay, thanks.
We're very excited about what you're doing, and know that these immunotherapies are giving patients more options and better options. So we are just thrilled.
Okay, thank you. Yes, and so I think we're thrilled too, and I'm very, very optimistic, that we'll be able to further improve the survival of the patients. And I think really the goal is really to use these novel immunotherapies to also, and maybe hopefully in a few years from now, to be able to achieve cures for the first time in multiple myeloma.
I know. We're so excited you're saying that word. It's a great word. So thank you so much for participating, and thanks for all you're doing.
Okay. Thank you so much.
Thank you for listening to Myeloma Crowd Radio. Patients can help support the discovery of a cure through our initiative, and we are grateful for all that researchers are doing to make this possible.
Hello, it is Ryan, and we could all use an extra bright spot in our day, couldn't we? Just to make up for things like sitting in traffic, doing the dishes, counting your steps, all the mundane stuff. That is why I'm such a big fan of Chumba Casino. Chumba Casino has all your favorite social casino-style games that you can play for free anytime, anywhere with daily bonuses. That should brighten your day a little. Actually, a lot. So sign up now at ChumbaCasino.com. That's ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.